So it's about time. Let's just give 1 or 2 minutes more for people to join, and then we could start. Can you hear me?
Yeah.
So maybe it's about time to start. Welcome everybody to this new series of the epilepsy surgery technique webinars. We are so '27. Just to update on you what happened in between, the World Federation of Neurological Societies has just created an epilepsy surgery committee, which is great news for the epilepsy surgery community. And these webinar series are now co-sponsored by the International Epilepsy Surgery Society, which, by the way, Cristine is the president, and the World Federation of Neurological Societies, represented here by me, who is sharing this new committee. We are excited about this webinar today. It will be the jumpstart of this series, and we are privileged to have these two great epileptologists that are gonna start the series. And after this, these webinars are gonna happen the first Sunday every month. So just be aware of this, and please join whenever possible. And after today's, we are going to start on temporal lobe epilepsy surgery. The next one will be on anatomy and history of epilepsy surgery. The presenters are Danny Spencer, that does not need any introduction, and Enrico Ghisoni, who is going to be talking on anatomy. But today, we are going to be discussing the tools for evaluating our patients and some patient selection criteria for neuromodulation. And without any other need for discussions, I would like to introduce our first speaker, Manjari. Manjari is the chair of neurology at her place in New Delhi. I don't think you need any further introduction, Manjari, but we are truly honored to have you here, and let's take the advantage of having you here, and please start your presentation. So we're going to be two 20 to 30 minute presentations followed by 30 minutes of discussion. And please, you in the audience, please participate actively. You can put your questions in the question box or in the chat. Thank you so much. Please, Manjari, go ahead.
Thanks, Arthur, and it's really a great pleasure to be here on this unique forum, which is essentially for neurosurgeons, but then epilepsy surgery is a networking, networking solution for the patients, and the networking is between neurologists and neurosurgeons and neuroradiologists primarily. Is my screen seen to all?
Yes.
Thank you. Am I audible to all?
Yes.
Okay. So I was asked to speak on the state of our tools in patients who have refractory epilepsy and need an evaluation for a possible surgical control. Now, we know that everything depends, a lot of good prognosis of epilepsy surgery depends on finding a lesion, and the lesion is essentially forming the lesional zone. But however, it's not just the lesion, it's the network around the lesion, which is formed by the duration of refractoriness and the etiology of refractoriness, which forms, to a certain extent, the ictal onset zone. And the ictal onset zone is definitely, somewhere around the lesional zone in most of the patients. However, we know that in between seizures, the patients may have an irritable cortex at various locations, and this is the irritative zone or the interictal spiking zone. We request as neurologists, the neurosurgeons, to remove the minimum amount of tissue which is required to make the patient seizure free, which is what is known as the epileptogenic zone. And the onus of locating this epileptogenic zone depends on various specialities which look into the preoperative investigations. So most centers which start out, which is the level 1 centers, would be able to do a symptomatogenic zone localization by looking at the semiology on video EEG, and then would be able to look at the scalp ictal onsets as well as the interictal to look at the ictal onset zone and the irritative zone respectively. And then, of course, a very good MRI, which will look at the behind the lesion. And the deficit zone, which is usually done by neuropsychological testing, or the PET brain, which gives us a functional deficit zone. Now, the propagation and ictal onsets can be made out from the scalp video EEG. However, at times when the lesion is subtle, or there are multiple lesions, or when there's discordance, we need many more investigations like a PET, a ictal SPECT, a interictal SPECT, and then a MEG. And of course, with a reasonable hypothesis, if we are able to find concordance between these investigations and we locate a lesion, we can straight away go for surgery, or we may have to put invasive investigations like a stereo EEG further into localizing, based on our hypothesis, the exact epileptogenic network. So really, a series of investigations is required, and many of them are done at higher centers where they are available. Now, each of these investigations forms a snapshot into the patient's network. And it's really to put these various snapshots together. That is the function of the epilepsy surgery team, which usually meets once in a week in our center. And these snapshots have various spatial and also time resolution stamps. So the time resolution, is not so good for MRI or PET. It could be good for a SPECT, particularly when you have the ictal SPECT, where you're injecting the tracer within 20 seconds of the seizure. Whereas if you look at other investigations like PET, it has a reasonable spatial resolution with a reasonable temporal resolution. And the EEG has a very finite, good, temporal resolution and also a spatial resolution. But look at the MEG. The MEG has a very, very minuscule, very, very early, within few milliseconds, a temporal, as well as it gives us a spatial resolution because we co-register it with the MRI. So these various investigations form various timestamps in patients with complex networks. Now, where do we need to do these investigations? We don't need to do these multiple high-profile investigations in patients who have a clear-cut mesial temporal sclerosis, which is concordant with the video EEG. So there's a right mesial temporal sclerosis, and all the ictal onsets are on the right mesial temporal, T2 or T4, and or F8, and you really don't need to go ahead with these complex investigations. But wherever you have subtle lesions, like focal cortical dysplasia type 1, and you're not able to make out the margins of the lesion, you really don't know where the lesion is encroaching, there H is highly advisable to do it or highly recommended to do it. You would want to do electrical source mapping by high density EEG. You would want to do an ictal SPECT, a PET, and of course sometimes even an invasive monitoring. So also when you want to monitor function, when you have lesions which are encroaching near the eloquent cortex, you will have, it is highly recommended that you would have to do, further investigations which could help you localize the functions and see that it doesn't overlap with the lesion which you wish to remove or the area which you wish to remove. So also in MRI negative drug resistant epilepsy, it is highly recommended. You can see the H across board to do all these advanced investigations, and this has been kind of laid out by the league in publications way back in 2014. So really, most of these advanced investigations which call for the team to come together, you need the nuclear medicine specialist, you need the neuroradiologist who's particularly interested in epilepsy, you need an electrophysiologist, and you need a good team effort to look at the patient, go back to the investigations, do a electrico anatomical clinical correlation for your patients. So one of these investigations is electrical source imaging, where we define the spikes, which are pretty much very spiky and have a very good rise time. And we do about a 64 channel or 128 channel EG. And we source these spikes by various software. And at our center, we do it with the BISA software. You can do a topographical mapping of the spikes, and you can see here that has been done of that particular patient. And then you can do a equivalent current dipole modeling, where you can look at the location, the spatial orientation, as well as the source of the spike. And you can overlay it with the MRI, which will give you a good kind of localization because it's fused with the MRI. So this is the electrical source imaging. And this pretty much can be done in patients who have either a 64 channel EG acquisition or a higher acquisition, which is more accurate than a lower channel signal. We can also do a Clara localization, and that will give you a kind of more diffuse, map of the whole source. And these are to be done by the neurologists with, of course, the trained personnel who are able to do it. Then, of course, the higher investigations involve high frequency oscillations. And, studies have shown that this is Georgia Ramantani's group, where they have shown in this paper that even with scalp EEG or your ictal onsets in the scalp EEG and your video EEG recordings on the scalp, you can define these HFOs, which range between 80 to 500 hertz, and you can localize the seizure onset zones, and they're very close to the seizure onset zones. So HFO analysis of the HFO with a wider bandwidth of your EEG systems, where you have acquisition of 10,000, can be done. Then, of course, Professor Ikeda from Japan has clearly shown in his group that we have slow DC currents, and these DC currents occur right at the ictal onset, and these are very low frequency, less than 0.5 hertz. And there's a baseline shift which happens, often appearing as a negative deflection. So you will see a very slow baseline negative deflection at the seizure onset, and these can also accurately map the ictal onset zone. So these are further advanced investigations apart from the routine EEG analysis, which we are very used to as neurologists. Then coming next to the neuroimaging, we know the league has laid down the harness protocol, and it is good to stick to this harness protocol because it has a 1 millimeter, sectioning of the brain with the 3D FLAIR and T1 MP range images and high resolution T2, which is about 2 millimeters. So it's really fine sections of the brain which can define various pathologies which are shown in the last column. And supplementary sequences which we do at our center is, of course, the arterial spin labeling. And we also do a DWI in most of our patients. Contrast scanning is really not required unless you're suspecting active infection, which is rarely the case in drug-resistant epilepsy. But post-processing of the MRI by morphometric analysis programs, by automated hippocampal volumetry, by cortical thickness mapping, and curvilinear reconstructions or reformats are advanced techniques which can be done, and they can be done after acquisition of your 1 millimeter section MRI. Voxel based morphometry, again, this is a very good technique, which involves various steps. As you can see, 3D T1, bias correction, tissue segmentation, spatial normalization, modulation, and of course thresholding. It's very operator independent, and it gives us a whole brain coverage. So really it is a very objective way of looking at the imaging, very useful for FCDs, heterotopias, etc. Then, of course, we at our center are using the machine learning epilepsy lesion detection. As you can see in one of our patients, you can see here that the MELD, which is the machine learning epilepsy lesion detection, has picked up this lesion, which is near the parasagittal cortex. And the confidence score here is 94%. So with 94% confidence, it has picked up the FCD, which is on the mesial surface. And this is really a unique way. It's, picks up 67% for FCD and 76% for FCD type 2 and 50% for FCD type 1. So wherever you have a very subtle anomaly, the MELD really helps you, and most centers, can be doing it. It's been published in Nature Medicine 2023. And it has, these are the stages by which MELD works. You can feed in 10 patients at a time, that is feed in 10 MRIs at a time. And it goes through, you can put it on in the evening, and next day morning, you have the results out. And it really helps in those patients where you have a good localization, but you're not able to get a clue on the MRI. So MELD is, a good way to go, particularly for focal cortical dysplasias. It can give a false positive rate of 18%, but really it is something which we do almost routinely for all our patients, which are on the first read of the MRI substrate negative. Then I told you about curvilinear or multiplanar reformats. When you really don't find much happening on your routine MRI, you can get the curvilinear multiplanar reformat, which will clearly show the area of focal malformation, which is seen in this particular patient. The other sequence we use is the EDGE sequence, which is enhanced detection of gray matter and epilepsy associated abnormalities, where you find a breach in the gray. You can see this, pencil-like drawing of the gray matter. And at one space, there is blurring, and there is kind of a diffusivity of where the lesion is, which is picked up on the edge. So EDGE is enhancing gradient echo, and it's very useful in bottom of sulcus dysplasias and subtle FCDs. So that's another sequence which we do, but we do it only in truly MRI negative epilepsies, because otherwise the MRI can go up to an hour. There is, of course, a DTI. Then you have NODI sequences, which can be done in the MRI to pick up lesions. And that really increases the yield of the MRI. So basically, utilizing both the harness protocol and post-processing techniques, it is possible to pick up subtle lesions which have been missed, because picking up the lesion converts a poor prognosis or relatively poor prognosis to a very good prognosis following epilepsy surgery. Then, of course, you can maximize it by fusing it with other non-invasive investigations like PET, where a so-called structurally normal MRI can show a deficit in the hypometabolism in that particular temporal lobe. We routinely do arterial spin labeling because, it is like the poor man's PET. It takes just 3 minutes extra. It's part of the epilepsy protocol. And you can see here, there is a subtle hyperintensity in the left temporal lobe, maybe plus minus in the coronals. But structurally, the hippocampus looks pretty much okay. But when you look at the ASL, there is a hypoperfusion in the left temporal lobe. This is further ratified by the PET MRI fusion. So suppose a center doesn't have a PET system, or the PET is expensive for the patient, a good ASL will give us similar results. So ASL is a good way to go. Then ictal spect, that is within 30 seconds or within actually 20 seconds of the seizure onset. And that is why ictal spect is done in our epilepsy monitoring unit, where we inject the ictal tracer within 20 seconds, and it has a good localization by 73%. We can also do SysCom, where we fuse it with the patient's MRI, which gives us pretty much a very good idea. In this MRI negative epilepsy, you can see here the PET MRI fusion showing a left temporal hypometabolism, and the SysCom also showing the similar localization. So really SysCom is the way to go. Utilizing PET and ictal spect and SysCom can yield good results over 8 years in our center. For temporal lobe, the outcomes were as good as 75%, and for extratemporal lobe, the outcomes were as good as 58%, just by having a concordance between these investigations. Then comes the MEG. Now, MEG is a very labor-intense, very expensive investigation. It's 306 sensors over the head, magnetometers and radiometers. It requires a coolant, which is liquid helium. It requires a magnetically shielded room, and hence it's very, very expensive. And of course, it measures the tangential dipoles. It does not get affected by volume conduction, so it has an upper hand over EEG. And it can pick up subtle, where you have these subtle findings in the MRI. You can have very good localizations. You can also study the propagation of the discharge in the MEG. And you can also, in large clastic lesions, you can also really make out where exactly the strength of the dipoles is. Is it a tightly clustered dipole? In patients who have subtle lesions like calcific lesions, which are very common in our country secondary to neurocysticercosis, the MEG helps us say, yes, the calcific lesion is indeed responsible for the seizures, as you can see here. And this patient underwent a temporal lobectomy. This is a patient who had a tuberculoma following tuberculosis, and the lesion was lying there, and this was the SysCom, and the MEG showed a tight cluster in the same area, and the patient underwent a lesion plus ECOG guided resection. So there is an additional yield of the MEG, particularly even if it's interictal, in that it adds a diagnostic utility of about 33%, and it avoids intracranial implantations to the tune of 20%. And we use it routinely in patients which are discordant, which have a normal MRI, which have multiple lesions on their MRI, which have large clastic lesions, and post-operative failures. We also compared the MEG with the SPECT. As you can see, the SPECT in this patient shows bilateral localizations, whereas the MEG is pretty much localizing to the anterior insula on one side. And then we went back to the MRI, and it did show a subtle dysplasia. Ictal MEG is possible in about 11% patients because we record the MEG for 3 hours. And you can see here in the MEG system, the patient has had a seizure, and this has picked up the dipole in the anterior insula, which was missed in the MRI. Now, the latest advance is, of course, this is not yet FDA approved, but it's undergoing testing in various centers in the UK. Cukiert has been doing it, and this is the OPM MEG, that is the optically pumped MEG. Now, this is supposed to be not requiring that liquid helium and the expensive, overlay for that liquid helium. It does require a magnetically shielded room, and it is much easier to do than the MEG itself. So the OPM MEG is probably the way to go. And as you can see here, this diagram shows us the difference between OPM MEG, which is done in room temperature environment, and the difference, closeness to the scalp is about 1 centimeter, whereas in the squid, the difference between the squid sensors of the magnetometers and radiometers is about 3 centimeters. So this is an upcoming investigation, and probably in the next few years, we should be able to get it into clinical use. We all know that we have to spare, essential eloquent functions in our patients. And previously we were doing it by a detailed neuropsychological evaluation. In our center, virtually, we have never used the WADA. We generally use the language-specific Hindi language comprehension MRI or word generation MRI to look for the Broca's area, to look for the comprehension area, and the memory tasks. And so fMRI is routinely performed in our patients wherever we are suspecting that it's near to the eloquent cortex. This is just to show you a few patients where this multimodality. So here there's this patient who's having, you can see here, focal seizures of the right upper limb. The seizure starts somewhere here. This is the BISA showing the localization here. And there is another investigation called the PASCOM, where we flip the PET, interhemispheric PET fusion. So we fuse the interhemispheric PET and we subtract the metabolism, and then we come with the area. So the PASCOM is showing a lesion here. This is the left side. So PASCOM left is left, like the MEG, and the SYSCOM showed localization to the right occipital lobe. And you can see here, sorry, the left occipital, SYSCOM was falsely localizing here. And you can see the MRI showing a gray-white matter differentiation loss in the left posterior cortex. So this patient actually had a left posterior quadrant dysplasia. Now, MEG also was the left posterior quadrant. So we did multiple investigations in this patient to reach to this conclusion, and she underwent a disconnective surgery following this. Another patient where there are seizures which look kind of hypermotor, but which are coming from the temporal, right temporal area. And the seizures mostly start with some movements of the lower limbs, bizarre movements of the lower limbs. As you can see here, he keeps moving his right lower limb. And the MRI is essentially normal. The ASL shows a doubtful hypometabolism in the right anterior temporal, which is ratified by the PET MRI fusion. The SYSCOM here is falsely lateralizing to both the frontal lobes. When you see the MEG is clearly localizing to the right temporal lobe. And so this patient undergoes a stereo EEG, multiple bilateral placements, and all the seizures are coming from the right hippocampus. You can see here the right hippocampus and the right insula, and this patient underwent a resection. The last but not the least is utilizing electrocorticography in surgical resections. We use it even after stereo EEG to mark the borders or mark the margins of resection. We map out the red spikes and the green spikes and kind of try to resect the area around the lesion, because again, the lesion is not the one which is the only thing which is epileptogenic. It is a whole network around it. Again, pertaining to the Indian scenario, this is a calcified neurocysticercosis with gliosis around it. And we've mapped it electrocorticographically. You can see the high spiking of the area where electrocorticographic resection of the area was done till the score reached almost a grade 0. So with this, I'd like to conclude by saying that using an armamentarium of advanced investigations with the networking of various specialities, the neurological, the electrophysiological, the neuroradiological, the nuclear medicine, the neuropsychological, and functional mapping techniques, whether it's electrical source imaging, whether it's high frequency oscillations, all are necessary to provide us various snapshots into the abnormal epileptic network in our patients. Thank you.
Thank you so much, Manjari, for this excellent overview on pre-surgical evaluation. We will continue with our second speaker, which is Cristine Cukiert from Sao Paulo. She's the chair of neurology at Santa Casa de Sao Paulo and the director of neurology and neurophysiology at Clínica Cukiert. Please, Cristine.
Hello, everybody. I'm very happy to be here and to talk to all this neurosurgeons and also neurologists. And as Manjari was telling us, so this is a teamwork. And after sometimes we can't find the exactly place to get out. So we'll talk about the neuromodulation in this kind of patient. So Arthur, can you I need to go to okay. And here, just a minute. Can you see my screen?
No.
Oops, not yet. Okay, just a minute. Just. Okay. And now I think that you can see, yes?
Yes. And
okay.
Can you, yes,
so,
great.
Okay. So we'll talk about the neuromodulation in drug-resistant epilepsy. So I think that the first thing is to identify and treating this different kind of epilepsy that is all that Manjari was talking about. So we first need to go to resective surgery if possible, but sometimes it's not possible. And then we can offer the neuromodulation for these patients, because not only to seizure control, but also to improve their quality of life and even to make the seizures lesser aggressive than like tonic-clonic seizures that we know that we have a high things from SUDEP, so in this patient. So this is something very interesting that we are seeing nowadays, that the decline of resection and sometimes the rise of modulation, because even with all this stuff to find the right place, sometimes not possible to find it. And so we can see the rise of modulation in our patients today. So sometimes we have this fewer clear-cut sclerosis cases that we are seeing many times now. So we don't see more like mesial temporal sclerosis patients. It's more difficult to see them. And sometimes we have to avoidance of morbidity risks of eloquent cortex. And so we can see here the drop of the resective surgery and the rising of the neuromodulation in this kind of patients. So modalities that we have nowadays, so we have the VNS, we have that it's an indirect one, we have the DBS, the deep brain stimulation, and in US we have the RNS, so we don't have outside US as we will see now. So this is something that I want to talk to you is the type of the procedure. So before we talk about this procedure as like a palliative procedure, and for now we don't want to tell about this palliative, because whenever we say the palliative, we are saying to the end of the line. But I think that the neuromodulation is a disease modifying. We are modifying the network. We are modifying the epilepsy network. So our goals is for sure the seizure control, but also, as I mentioned before, the seizure severity and the lower the risk of SUDEP. And with all of these things, we will have the better quality of life, not only for the patient, but also for the families, especially with the very sick kids and the like encephalopathic kids, that sometimes when we offer the neuromodulation, we can change their lives in some way. So this is a meta-analysis and that we see by Anglo and Dario. So they put together all the VNS, DBS, and RNS, but this is in the time of the implantation, and we see with all the neuromodulation, we see here that the responder rate in the beginning is 1, and when we go in a long term, is the responder rate is much better than in the beginning. So I think it's like wine; they are getting better with time. And when we compare the three modalities, we see here, and all of them almost, we get some 70% of response, or not only the response, but the better quality of the seizures. And another thing that is very important, and when we see these patients, we can see here that in long term, we have many of these patients, they are very, very sick, they are very encephalopathic. Some of them, they get seizure free with neuromodulation. It's not something very expected with the modulation, but sometimes we can see some of these patients in seizure-free mode. So we'll start to talk about the VNS. What about the VNS indications? When we indicate the VNS for people. So this is very old. So this is in 2011 in the seminal works, but I think it's very, very useful till today. So when we choose the VNS for people, so when they have a multifocal or diffuse seizure that not amenable to intracranial surgical resection, persistent or recurrent seizures following intracranial epilepsy surgery. Sometimes when the person don't have that, they have the toxicity with many medications. And something is very important here, especially for kids. We see some kids with many medications, something like 4 or 5 anti-seizure medications. And we know that these medications is very deleterious for this developing brain. So I think that we have to think about the VNS before, very, very in the onset of the seizures. So the medical unfitness for intracranial surgery. And here, not patient or family preference sometimes, so they prefer the VNS instead the DBS because these are a lesser invasive procedure. So this is a very interesting, so I was mentioning before. So we have here that with the time, so here we have, oops, sorry. In the beginning, so I mean a seizure reduction with 30%, but when we see here in 4 years, this goes up to 70%. So this is very interesting that we see over the time with the response for the VNS with these people. This is the pivot trials, and also showing here the very better response with the time. So we know that VNS, now we have the cardiac based closed loop. So some of our patients get improvement of the technique with the cardiac based loop of VNS. And here we have some of our works in very beginning. So this is 2012, but we show that some patients have a very, very good tolerability with high intensity in atypical absence, myoclonic, and generalized tonic-clonic seizure. And this is a very interesting thing because in the beginning we just go up to the amperage, but for now we know that we can modulate many other issues of the VNS, like the time, the on and off, and so we can get better and better response for each patient. So, and with the new devices we have, so we can program in different ways, like a night or day. So we have many different patterns that we can choose for make these patients have a better response for the technique. And this is another interesting thing, so that we can see also in our patient that we have the better response for our patients to VNS with the generalized epilepsy. So we have many of our Lennox-Gastaut kids that goes to this VNS and have the improvement of not only for the absence, myoclonic, and also the tonic-clonic seizures. I think that the worst seizures we have a better improvement is for the tonic seizures. And when these patients that they have the atonic seizures, so these patients we go to callosotomy, that we know that the response for callosotomy is much better than the other techniques for atonic seizures. So here we can see when comparing focal, so this is, they have the partial seizures because it's a old, it's 2016. But when we compare the focal and the generalized seizures, we see here that the generalized seizures, they go better with the VNS than the focal seizures. But sometimes we have patients that have focal epilepsy and with a diffuse disease, and then sometimes we have the better, a good response for them also. So, and this is an AI image, but I think that is a very, very emblematic, because here we see a kid, and here we see the clock. Yes, and then we have to think about this kind of population because they have different causes. They have seizure and anti-seizure medications that are deleterious effects in the developing brain, and they have the functional plasticity. So we have to think about all of these things in the pediatric population. And then we have to go very in the beginning for these patients, not waste time with these patients to go to this kind of neuromodulation. So time matters, especially for the pediatric population. And this is a very interesting that we have from last year, from 2025. And this is the refill gap in Lennox-Gastaut management for this patient. So this is the international guidelines. If these patients have the failure for 2 medications, they must go to surgical evaluation. But it's not we see in the reality, because we see these patients going to many trials, medication trials, before going to, we have this delay gap before going to surgical evaluation. So they go to 3 to 4 medications before. So I think that we have to think about it and to refill these patients much earlier for the surgical evaluation. So consider earlier VNS, especially in children. Well, and which are the predictors of better response for the VNS? So as I mentioned before, the generalized epilepsy, the VNS implantation in the beginning, so if less than 10 years at the onset of epilepsy, and then the patients that are implanted over 10 years after epilepsy. So we see that the patients with less than 10 years, that they have a much better response than the other ones. And the other thing is the epilepsy beginning after 12 years. So this is another good response. And we have to think about the complications. So here we have the hoarseness, cough, paresthesia, but we need to think about the sleep apnea, because in these patients, sometimes they have a worsening of his sleep apnea in almost 50% of patients. So be attentive for this kind, for these kids, many of them, they have this sleep apnea, and some of them, so they have this worsening. So many of these children, I have a patient 2 weeks ago that was going to the polysomnography, and then we saw a very bad situation with the VNS. So, and then we modulate the parameters like the frequency and the amperage, and this patient goes much better. So don't forget about this thing in these patients. Well, let's move to DBS. So the DBS, the very well-known study, the Sante study that went to the anterior nucleus DBS. But for now, we know that we have many more nuclei. So we have the very not new, but very nowadays it's a very well-known target, the central median. And the central median target is very nice connections with this motor area. And these patients, I think that we'll talk here. So this patient with the central median DBS, they are very good for this generalized epilepsy patients. And here for the anterior nucleus, so we have the connection, especially for the frontal lobe and also for the temporal lobe. So these patients, in the beginning, so they were treated for every kind of epilepsy, but nowadays we know that the response is much better for the frontal lobe and temporal lobe epilepsy. So here we have the new targets. So we have many studies going now with the pulvinar, especially for the posterior epilepsy. And here we have also a study going with the Hal Blumenfeld in Yale, that they are stimulation for the START trial. They are stimulating the centrolateral, just to trying to put less restore arousal for this patient. And this is another kind of a study that we have in children. So we have a systematic review, the DBS in children, especially for the Lennox-Gastaut patient, showing the outcomes are very good and nice outcomes in this kind of patients also. So I think that the criteria for DBS and VNS in these patients, they are very much the similar criteria, but sometimes we see that the DBS has a better response than VNS. But sometimes, as I mentioned before, the family, they prefer a less invasive procedure before a more invasive. So many of these kids, they go to VNS first, and many of them can go to the DBS after. And here, so we have some of the trials that some of them, they are going, or some of them, they are finalized. So here we have the Nautilus trial that they are putting RNS in central medium. And here we have the cadet trial, the pilot and the trial. So they put the PIC-STIM. It's another device in the central median for these patients also. So we have many trials going. So here we have another one, like the deep brain stimulation versus vagus nerve stimulation for epileptic spasms. So we have many. So this is the very big question, so the golden question, which is better? I think that we have to target a specific for that, individualize the neuromodulation for that patient that we have in front of us. Well, this is another very interesting, from the last year. So comparative efficacy of neuromodulation therapies in Lennox-Gastaut syndrome. And so here they were comparing the DBS, RNS, VNS, and showing a response of almost 70% and in between 60 and 70%. And so they show that the DBS is significantly more effective than the VNS. And in the DBS group, later epilepsy onset predicted better response. And also we have to think that in the VNS, we have many more patients than to DBS and RNS. This is very important to think about. And so we have the quality of life and safety for these patients, and also the adverse events. So the VNS is mostly stimulation-related side effects. And for the DBS and RNS, we have high rates of serious device-related complications like infections and the others. So showing that VNS is more like I've mentioned, more less invasive for these kids. So the ANT mentioned before. So here, for this, so this is modulating the limbic circuit, input also to hippocampal and frontal and cingulate cortex. So this is it's a procedure that is we have to choose for frontal and temporal lobe. In our center, we don't put in temporal lobe because we put the DBS targeting strictly to the temporal. So the central median stimulation, as I mentioned before, so we have the generalized epilepsy or multifocal epilepsy, especially for the modulation of the circuit of the reticulothalamic circuit, and also the activating the ascending reticular activating system. So this is very interesting that we see in some of these patients, we see a very better attention improvement. So with some of this targeting of this specific reticular activating system. So this is the STEL, the STEL trial. So the STEL trial, so that was performed there in Australia, showing that they show they didn't have the better response clinically, but they have a very nice responder rate, especially for the electrographic seizures. And so for the CM-DBS in epilepsy, so the patients with the Lennox-Gastaut, or we call Lennox-like syndrome, like a secondary generalized epilepsy, patients with refractory primary generalized epilepsy, or patients with or without previous disconnective surgery, or VNS. And here, so we have this a very nice paper from Valentin showing that very, very nice response to generalized epilepsy. Well, this is another our paper showing that we have a very, very mean reduction, especially for the tonic-clonic generalized seizures, and also for the absence seizures. And this is another very interesting thing that we show. This is an observational study, but we show that when we put VNS plus DBS, so like in addition mode, so we have a very nice better response with the two neuromodulation system. So as I mentioned, the hippocampal DBS. So the hippocampal DBS we use here, especially in the patients that we have bilateral temporal lobe epilepsy, or patients already submitted to resective surgery without seizures coming from the non-operated side. And so we have a very nice response. So here we have the DBS in loco, and we can see here that we have a very nice response also for the awareness seizures and with the focal awareness seizures in these patients. So here we have the pulvinar, the new target. So we have some work doing in this, but for these patients, the indication is for the posterior quadrant epilepsy. So the DBS in epilepsy, anterior nucleus for the frontal temporal or temporal epilepsy, centromedian for generalized epilepsy, hippocampus for temporal lobe epilepsy, and pulvinar for the parieto-occipital epilepsy. When we move to RNS, the RNS is a technique that we don't have outside the United States till now, but we have for the patients with the focal seizure onset, especially for the patients in eloquent areas like the primary sensory motor gyri, calcarine cortex, frontal and temporal speech memory areas, or in patient 1 to 2 foci epilepsy. The very nice thing for this technique that we can record, so they can sense, and after they can detect and then stimulate. But we have a very nice recording system, so we can not only treat these patients but understand much better the epilepsy as a total. This is a very nice paper showing a 9 years follow-up for the focal refractory patients. Also, as we see also in VNS and in DBS, we see in RNS the better response with time. So here we see year 9 showing like 75% of responder rate in this kind of patients. Well, and this, so we have the multi-target and synergistic approach. So here we have many patients with VNS plus DBS, VNS plus RNS, and the takeaway of this situation is the combination is viable and safe, and the effects appear additive rather than synergistic. And this is the reality check of global disparities in access. We know that it's very difficult especially for the neuromodulation in the places that we don't have access. But I think that for now, much more patients can be treated with this kind of treatment. So I want to end here my presentation that one target fits all, no, and then one neurostimulation fits all, no. This is not true. We have to individualize the patient. The optimal stimulation technique, targets, and programming may be syndrome specific, and I go further. I think that may be individual specific. Thank you.
Thank you so much, Cristine.
So we are back, and we do have time for discussion as usual. I guess this is the most important part of the webinar. We do have some questions from the audience, but maybe we could start with questions within the panel. Cristine, would you like to start?
Yes. So one question that came to my mind, Cristine, was in the beginning of your presentation, you mentioned that epilepsy surgery is going down and neuromodulation is going up. Would you agree that this is also dependent on the region in the world that we are facing? Because I can imagine that there are regions in the world where epilepsy surgery hopefully is on the rise for now and will increase hopefully. But any thoughts on this?
Yes, for sure, Cristine. I totally agree with you. I think that I put that slide just showing like how worldwide, but totally agree, because there are many places that we are trying to get epilepsy surgery there. So many remote places and so we are just trying to start the epilepsy surgery programs in this. So we are here, all of us are involved in this. But in many centers, as Manjari show us, so there are many people. They like we don't have all this kind of MRIs and techniques and everything. So I think that we don't need, we can't stay just looking to that and not doing something for them. But I totally agree that in many places, especially that we treat all the lesional cases. So I think in these places that the neuromodulation is rising, but in the other place that we don't have access to even to epilepsy surgery, for sure that we are starting with the resective surgeries.
Thank you.
Would you like to comment on this, Manjari?
Yeah, so, for a resource-limited setting, in most of India, our socioeconomic status is not so great for neuromodulation. So typically, it is very expensive. And particularly VNS, they haven't yet come out with rechargeable batteries. The DBS does have a rechargeable battery. So, there is an upper hand in the duration of modulation by DBS. However, VNS, very often by 5 to 6 years, depending on the battery usage, exhausts itself, and then you have to replace it, which becomes even more expensive. So we save these procedures for those patients where we've investigated almost everything and found that there is no reasonable hypothesis being generated. We also save these procedures where there's bilateral hypoxic damage and seizures are coming from both sides. We also save these procedures where there are like a Lennox-Gastaut syndrome without a lesion like a FCD. So we save these for the most, severe refractory epilepsies where we haven't managed to find a reasonable hypothesis for either resection or disconnection. We also subject all patients before they undergo this expensive neuromodulation to dietary therapies. So the typical protocol is investigate them. If they are not cleared for resective or disconnective surgeries, Then we go ahead with dietary, which is ketogenic diet and modified Atkins diet and low glycemic index diet. We find a reduction to a 30 to 50% by this procedures itself. So this is much more inexpensive for our patients. And still, if the seizures are continuing, we go ahead with the neuromodulation. Now, in children less than 10 years, we prefer corpus callosotomy for those who have drop attacks and Lennox-Gastaut syndrome, because corpus callosotomy in our setting is very inexpensive. So, we have to choose the option depending on the investigations as well as the socioeconomic impact on the family.
Totally agree.
That's interesting, because I agree. What probably Christian intended to say, that this might be center dependent, and I think this is very true. For instance, we don't see patients with lesions anymore. These patients are inoperated in other centers. Almost all of our patients are MRI normal. So, and this complicates things, and that's probably why we are seeing and using much more neuromodulation, because many of these patients don't have a very good hypothesis for resection. And more recently, what we have been doing is we included thalamic target in the SEG, because most of these patients go to SEG if they have normal MRI. And then we are basing our decision on where to modulate on the findings of thalamic SEG. The other side of it is that the thing is, we had a kind of, over the last couple of years, maybe a decade, we had a kind of a hype of SEG. So everybody's doing SEG, and lots of it. But the fact is, it's in the best hands, coming from the very well-known centers in Europe. Around 30% of the patients who undergo SEG does not end with resective hypothesis. And this is what we are seeing. We are seeing an increase in SEG investigation and a decrease in the number of resections, which probably means that we are doing more SEG than the traditional one. But then if you include thalamic recordings in the SEG, this is another thing. But I just want to move ahead, Manjari. You showed this nice tools and etc. Could you tell us how often these new tools avoid implantation in these patients?
Yeah. So, absolutely.
Traditionally, we see video EEG, MRI, and the patient, and then we have an idea. And then tell us what these new tools can add, and how much often this end in avoiding the implantation.
So, if you read the literature, at least for magnetoencephalography, the conclusion even of the American Academy of Neurology is that the MEG is a non-redundant tool in evaluation of patients with drug-resistant epilepsy, where you do not have clear-cut lesions like MTS, DNET, gangliogliomas, cavernomas. Subtle lesions, multiple lesions, post-operative lesions, large clastic lesions, normal MRI, functional overlap. MEG is very useful. In our own series, which was a prospective series, we found that MEG obviated the need for stereo EEG in almost 20% of patients. So in 20%, we got away with concordance of various investigations, including MEG. And going back and looking at the imaging. Typically these patients get discussed several times in the meeting. Typically 5 to 6 times before we reach a conclusion that, yes, there is something here, it is seen, it's concordant with the MEG, it's concordant with the SysCom, and particularly in temporal lobe, MRI negative temporal lobe. That is where we do a resection without a stereo EEG if everything is concordant. For extratemporal, it's a different ball game, because the margins of resection will vary. And there, then particularly the frontal lobes or the insula, we tend to go ahead with stereo EEG. The stereo EEG is done after maximizing the non-invasive investigations and coming to a reasonable hypothesis. We do stereo EEG for 3 reasons. One is to localize the focus. The second is to stimulate and produce similar seizures and see which area produces similar seizures. And the third is we ablate the area from where the seizures are coming, provided we've got very focal onsets. So this gives us a kind of diagnostic and therapeutic confidence, because after ablation, we explant the electrodes and follow up the patients. And if they remain seizure free for quite some time, then we know we've hit the right hypothesis, and then we go ahead with resection at a later stage. So I think, as you said, even our center, because ours is a tertiary center, we are rarely getting mesial temporal sclerosis now. We are getting normal MRI or multiple lesions or complex patients more than MTS, DNETs, which are getting operated in tier 1 centers in the country. So really we are ending up with more complex patients, and definitely you need to do a much wider range of investigations for these patients rather than just video EEG and MRI.
Thank you so much for that, Manjari. I heard both Cristine and you mention the issue of pediatric epilepsy surgery and how early we should aim for it. And I know this is Cristine's passion, and I know there is a very nice paper coming from you, Manjari, regarding this. So can you elaborate a little bit more on how and why early pediatric surgery is evaluation, at least, or at least refractory pediatric epilepsy evaluation is urgent in the pediatric population?
So, these little kids, right now we have a 3-week-old baby in our neurosurgery ICU with continuous convulsions due to hemimegaencephaly. These children come with so many seizures. They invariably are, in the ICU, and you can't wait. You can't wait. They're on multiple drugs. So the youngest we've operated is actually, I think, 6 weeks. And now we have a 3-weeker with us. So really, these children who come with almost like continuous seizures, they warrant early, investigations and surgery. You can't tell them that, we are going to wait for 2 drugs, then the 3rd drug, then the 4th drug, then the 5th drug. Whereas, older children, it's a little different. They may have 2 or 3 seizures a day or 2 or 3 seizures a month. There you can kind of wait a little longer. But generally at our center, kids tend to get operated much earlier than adults. The reason being, there's a growing brain. We know they get into encephalopathy. We know the impact of anti-seizure medicines. So, and they're much more challenging, and much more complex. So I think pediatric epilepsy surgery is something which has to be done at a war footing. You really can't wait trying to, see if the seizures are going with the 3rd drug and the 4th drug and the 5th drug. If you find the lesion, you go for it.
I think that is very important, especially now that we have more and more medications coming up. And I think especially for the neurologists and child neurologists, it's very, very important to think if you have if you have a lesion, don't wait. Go. Yes, go for surgery, and don't wait for a life to send these patients for surgery. No, Manjari, because sometimes we see that our colleagues, they think about the surgery as the end of line. I'm not talking about the neuromodulation. I'm talking about all the surgeries procedures. And I think that so we have to change this situation. I think that we are already doing that and send these kids much earlier to surgery.
Absolutely. It also has a huge cognitive impact, behavior impact. The children get impacted on almost all domains. Yeah.
Mm-hmm.
And it's likely that the medication burden is higher than the seizure burden in many of these kids.
Yeah.
Could you tell us what is the impact of these new technologies for evaluation of patients in your center in Austria?
So we don't have a MAG at our institution, but we have one MAG in Austria. So for this, we're sending people to this center and discuss the results and the and also the results of the other pre-surgical evaluation tools with them. Basically, as you mentioned, we are a center where we get, referrals from the whole country. So we're doing children as well as adults. So, and we are seeing more and more complex cases, as you mentioned, and we are seeing more and more children, because it seems that people in Austria, the physicians, the child neurologists, pediatricians, are seeing that they should refer patients earlier, and as the rest of the world is working on that, it seems that it is working it starts to work in Austria. So it seems that this treatment gap is getting smaller and smaller. So this is, I would say, good news. And what we are seeing in adults is that the typical hippocampal sclerosis patients are almost operated. And the numbers for this are very low right now. So it could be that, many patients are now captured during childhood and are operated already during childhood or early adolescence. And in adults, we're seeing, MRI negative complex cases, as you said, where pre-surgical evaluation is very tricky, and where we use all the technology that you were mentioning, Manjari, and where there is, as you said, there is no, and you said this, Cristine, as well, there's no one fits all, and no one good tool and one bad tool. It's all about combining all the information from all these tools. The more information you have, the better the results could be on one hand, but on the other hand, the more results you have, the more complicated it gets, and the more tricky it is to get your decision, to get your plan. So this is the situation in Austria nowadays.
We have a question from Dr. Hagavendra, I guess to Manjari. It's about BESA and its localization accuracy to seizure onset and seizure freedom in operated case of drug refractory epilepsy.
Yeah, so we are routinely doing brain electrical source analysis for our patients wherever we think that there is a subtle lesion or normal MRI. It is if you find very good spikes, repetitive spikes, monomorphic spikes with a very rapid rise time, it has a very good specificity to the localization. And electrical source imaging fused with the MRI really tells us the location of the source and the orientation of the source, the positive and negative dipole of the source. So the sensitivity in various studies has ranged from 75 to 90%, and specificity is around 50% or so. Some studies have shown a lower specificity. So it's an additional tool. All you need is an EEG, and any center which is doing invasive monitoring will have a EEG system which is more than 128 channels. So a minimum 64 channel EEG. Now you have good head caps. So all you have to do is to put the head cap and do the source localization based on the selection of the spikes and application of the software. I think we were fortunate enough to have Stephen Ramp come to India, come to our center, and he kind of trained our manpower on source BESA. So we learned from him, and we are doing it quite routinely in patients who are MR negative or have subtle lesions or multiple lesions. Yeah.
So much, Manjari. Go ahead.
My question. So we were talking about the price, yes, for the neuromodulation. And what about all these tools, yes? So comparing how, because I think that's another thing, Christian. So it's very hard to have neuromodulation around, and it's very hard to have all of these tools around also, yeah.
So, you'd be surprised to know, in India, at least in the public health setup, which is where I work, I'm in a government hospital, all the investigations are almost free of cost. There's no costing. Our MEG is just 3,000 rupees. Our MRI is 3,000 rupees. Now, 3,000 rupees would be how much? It would be uh, 30 US dollars. So our MEG is 30 US dollars, our MRI is 30 US dollars, our PET is 30 US dollars. So the investigations are very, very inexpensive. Whereas if they have to undergo a neuromodulation device, that's an out-of-pocket expenditure because that's very expensive. So stereo EG purchase is an out-of-pocket expenditure. So stereo EG purchase, neuromodulation is out-of-pocket. Epilepsy surgery, phase 1, that is just a MTS and removal of the MTS, is 36,000 rupees, which will be, I don't know how many dollars. But if it's invasive monitoring, it becomes a little more expensive. But out of pocket will be what the patient buys, which is the device and the stereo EG electrodes. Hence, it's easier for us to maximize the non-invasive investigations than put a neuromodulation device.
I think it depends on the specific place, yes.
Yeah, absolutely.
We have a question here, I guess, for Cristine about memory during hippocampal stimulation. Tell us something about it.
Yes, we just published that now, so we don't see any deficits in temporal DBS. Because we were worried in the beginning, but we just published it. It's in epilepsy. It's where Arthur saw the publication.
It's epilepsy. It's epilepsy. Huh? It's epilepsy.
Yeah. Epilepsy. Yeah, just now.
Okay, would you like to add something, Christian?
Well, no, I just wanted to point out, because I guess many of the people listening today didn't come along epilepsy surgery so far, probably. So, and all are in regions where all of these evaluations are not easily done. Just to point out that an MRI, a good video EG with a lesion go for surgery, surgical evaluation at least. So I think this is a message for the young neurosurgical residents that, as you said, Cristine, epilepsy surgery is not a treatment of last resort. It's the treatment of first choice. And this is important because this is also in, neurosurgical residents' head, probably also in my country, that epilepsy surgery is not at the end of the treatment. It's the evaluation, at least, is at the beginning of the treatment. That's important.
Totally agree.
Welcome, Purdue. You're hiding. Do you have anything to add? How this new technology for patient evaluation impacted in your center in Sweden?
Well, we don't use MEG so much because we have to send them, but we use them in a few selected cases. But we have, of course, the best new technique we have is LIT, actually, which is very efficient for hypothalamic hematoma and so on. But I think the most important thing is that the MRI technique is going further and further, and we are very much using the intraoperative MRI to verify the resection during surgery, which has been very important for us.
How the use of intraoperative techniques, be it imaging or neurophysiology, is going to be something that we are going to be discussing in another webinar. I know people are often have discussions about how useful is intraoperative MRI, how useful is electrocorticography. and things like that. But this is something that we are going to discuss in another webinar. But right now, I just want to say how fortunate we are for having Manjari and Cristine here today, sharing their knowledge with very nice presentations. And I invite you all to be present in the next webinar in the first Sunday on on June. That will be on temporal lobe epilepsy surgery. If that, Christian, could you say, Bertu, could you say some final words?
I must say that this has been a very, very good review of the basic epilepsy surgical principles. Manjari, you did an excellent going through every these techniques, and you, Cristine, for the alternatives for resective surgery on Optivator. So it has been a really great session. Thank you so much.
Thank you.
Thank you.
I couldn't agree more. Nothing to add.
Okay, so thank you all for this fantastic webinar, and let's get together again the first Sunday of June. Thank you so much for it.
Thank you. Enjoy your day.
Bye-bye.
Bye-bye.